am excited to jump into this panel with friends and colleagues, and we are going to be speaking about resourcing resilience. How do we continue to invest in bold innovations across Africa? But before I frame up our discussion, I want to turn to our colleagues to introduce themselves, and I'll ask you to tell us who you are, what you do, just very briefly in a sentence or two. And then, because Trevor Noah last night had to provoke us with a question about who wins the Jollof Wars, and for any who don't know Jollof rice, it is a delightful blend of rice, tomatoes, onions, and in my case, where I grew up, Liberia, Liberian hot peppers. It is there's a long battle that's been going on in West Africa. And because we have Angela from East Africa, we actually have a neutral referee. So I'm going to start with Bright and ask you to introduce yourself and tell us who wins the Jollof Wars, which Jollof rice is the best. Then we're going to go to Kelechi. And by the time we get to Angela, we're going to settle it. Liberian Jollof rice is, of course, I will take moderator privilege here and tell you that because of our hot peppers, which are out of this world, we have absolutely the best Jollof rice with some smoky dried fish, which as a vegetarian was the hardest traumatic thing to leave after I switched over to being vegetarian about a decade ago. But I still will go after a veggie Jollof rice, which isn't as good, but it certainly tops Ghanaian Jollof rice. But I'll turn it over to Bright to confirm that for us.
So am I only talking about the Jollof rice now? I also have to introduce myself.
Yes.
Okay.
Yeah. Do your intro and then tell us which your vote.
Great. So my name is Bright Simmons. I do two things. I work on technology for supply chains. So we build technologies that track products like medicines and other important goods like agri-inputs throughout the entire supply chain in a number of African countries and also in India and China. And I also do a lot of policy stuff. Regarding Jollof, there's no debate because there's been randomized controlled trials end to end, across the continent, and Ghana came up on top without question.
That was good. I see what you did there. It's, Kelechi, please introduce yourself and give us your vote, which I'm not sure which way it'll go, but you can surprise us if you want.
Well, thank you. Good morning, everyone. My name is Kelechi Ohiri, and I am the Director General and Chief Executive of the Nigerian National Health Insurance Authority. So one of the few government folks and policymakers here at the forum. And my primary preoccupation is how to help Nigeria move towards universal health coverage, which is, no mean task. And something I am excited about and happy to speak more about. With regards to Jollof rice,
Remember, you're still working for government.
Ghana talks about randomized controlled trials, everything, but once you taste Nigerian Jollof, it settles it. So, absolutely.
Well done. Very diplomatic, actually. All right, so we're going to settle it. Angela, please introduce yourself and then give us the final verdict.
Indeed. My name is Angela. I'm part of the team at the Financing Alliance for Health, and I also co-lead the Africa Frontline Fast with Amazing Nan, who's in the audience here. My role is around health financing and increasing financing for primary and community health systems. I come from the land of bland rice, and so I also think I have the emotional bandwidth to be able to withstand a rebuttal from my Nigerian big brother in case I don't say the right thing. So I feel that, I think everything is good. in different measures, and I do think that there's room for all kinds of jollof. And I want to bring our other brother into this conversation, the source of jollof rice, which is Senegal, who seems to be very quiet in these wars. And, I don't know if I am in the right place to make a decision, because I don't think there is a decision to be made. There is room for all kinds of rice, everything, all kinds of rice to play. So I am very careful about being able to preserve myself and to exist in the future to do amazing things without, unnecessarily rocking certain boats that can cause challenges. So as we can see, I think we're all agreed that, that's the best rice. That is, no, I did not name any country.
Well, that was what you've preserved your visas to all three countries. Well done, well done.
I want to be welcome everywhere, yes.
So this morning, we're going to speak about, as I mentioned, resourcing resilience, especially in a very fragile context. Global health and local health, which is what global health is made of, and is in a very fragile moment. All of you have been tracking or directly affected, or the communities you work with have been, whether you work in health directly or not. Health is the basis of life. So you may be doing other work, and you've been tracking over the last 2.5 months in particular. There has been massive risk and threats and attacks on global health. We have had 25 years of progress in global health. Over the last 25 years, we've seen maternal deaths, preventable maternal deaths, fall by over 40%, or about over 30%. We've seen preventable newborn deaths fall by over 40%. We've seen HIV, TB, and malaria deaths, the three biggest infectious disease killers, the death rates there drop by over 60% in the last 25 years. And that's been the combined work of folks on this stage, in the audience, and around the world, including those watching online. That is now under threat and being attacked. The US government has pulled back dramatically and essentially nixed a number of global health programs. That's led to what will likely be billions of dollars of disruption in global health care delivery. But the UK government and the French government, the German government, have also cut back on global health assistance and development assistance. And we know that before these big shifts, that while there had been progress over the first 25 years of this century, progress had been stalling. When I was the head of the US President's Malaria Initiative, we were working with countries like Ghana, Nigeria, Kenya, to cut the death rate from malaria further. We've been rolling out the world's first malaria vaccine with a number of colleagues from your countries and others around the world. And yet, we knew the death rate decline had started to stall. Then COVID happened, and that stalled it even further. And we know that even during COVID, we saw the fragility in our health systems in Africa, in some ways exposed, because vaccine access was challenging at the beginning and inequitable, to be sure. And then when vaccine access was available, getting the vaccine out was also challenging. So this is where we are at the moment. And what we would like to do today is to talk about where we are now and to talk about where we want to go. Because while there is a dramatic amount of change, as my mother likes to tell me, when change happens, some doors close and other doors open. And there is an opportunity, unlike any time before, for our community, for social entrepreneurs, for healthcare policymakers and entrepreneurs and philanthropists to remake the global health system, and to do that in the place perhaps where it matters most, because the burden of disease and the lack of healthcare resources to deal with that burden of disease is highest in sub-Saharan Africa. So that's where we want to take the conversation. And we also want to talk about how we're going to get there and what we all might do to help us get to that re-envisioned, reimagined new future. So I want to get started with Kelechi. When I was in government, we always were tossed the hardest questions, and I'm not going to make it any easier on you than it was on me. But you have a really important role as the head of the Nigerian health insurance agency, or you're overseeing the health insurance in Nigeria. You're thinking about how the government itself and its partners locally can deal with this sea change in funding. Just to put it in perspective, like just in the malaria program alone, we were partnering through U.S. funding just about tens of millions of dollars a year just for malaria. Then you put HIV, and then there's other maternal child health funding. Nigeria was one of the largest partners to the United States on health. That's now being pulled and disrupted. So tell us where things are now in Nigeria and how you're dealing with this moment.
Well, thanks for the question, Raj. And I think it's important to also look at the trends and the prelude to where we are now. And Nigeria, like many countries, has been going through multiple transitions. We have had the epidemiologic transition, where we have burdens of disease, where chronic diseases are increasing. It used to be a sixth of the burden of disease, now it's about a third. So we're dealing with this, duality in terms of the burden of disease. We've also been going through questions around transitions in development assistance, where with many of the multilaterals like Gavi and Global Fund, increasing need for paying more co-financing for those services. And also the demographic transition, right, with the youth bulge, etc. So it's been a period of transitions. Continent-wide, we also know what happened during COVID, which you've highlighted, where the premise of global solidarity was tested. And a lot of African countries began to look at opportunities for building resilience inward, whether it's by local manufacturing or by looking at taking a different look at financing healthcare in general. And then this current crisis happened, right? And it happened against the backdrop of countries not recovering from COVID fully, macroeconomic headwinds, particularly with, growth stalling, currency devaluations, rising inflation. So not a very pretty macroeconomic picture, which meant that countries now needed to begin to prioritize differently and look at things differently. When the US government decided to take a different path in terms of development assistance, and other countries followed suit, of course it was a shock to the system. And I think our reaction has been, first, we appreciate and thank, the US and other countries for the partnership and the support over the years. And a lot has been achieved. But then ultimately, the responsibility for one's citizens is with the government and the country. It's a responsibility we can't abdicate or outsource primarily. And so with that realization, Nigeria began to look inwards. Well, first things first, get over the shock, right? It's happened, you have to deal with reality. Secondly, how do we mitigate the impact and the harm? So in Nigeria, for instance, $200 million was mobilized and approved by the House of Representatives and the Senate, where we looked at, filling the gap occasioned by the exits. Mm-hmm. There were about 23,000 health workers. About 11,000 of them were full-time health workers, and about 12,000 were voluntary, and the government has absorbed these health workers. And then we're also looking at ways for, defining efficiency opportunities. There are lots of big numbers which are thrown around, but how much of that actually gets to people? And so it's also created an opportunity for more efficiency in the systems. Can we streamline our supply chains? Can we integrate better into the system and therefore reduce the cost of actually providing and sustaining these services that are essential? And then to begin to think longer term, what do we do in terms of sustainable health financing? So it has forced, the country to begin to look inwards and to be more resourceful and efficient in the way we are addressing this. Mm-hmm. So that has been, the impact. But that said, I think we have to also imagine a world in which things may not come back to status ex ante. Mm-hmm. So we have to prepare for that new reality, right? And then what does that look like? I also chaired the Health Financing Committee, where we work in collaboration with donors and the Ministry of Budget and the Ministry of Finance in Nigeria to look at health financing broadly. And I think what we want to chart out right now is, the pathway for ensuring, coverage. So things like integrating HIV, TB, and malaria into the benefit package that is covered by insurance is one of the things we're proving the concept right now in collaboration with the Global Fund, with a view to making that part of the benefit package. And
what package? You said?
The benefit package, mm-hmm. right, for insurance, so the minimum benefit package. Because as you're aware, actual costs will actually be cheaper than paying the average cost. So by pulling this risk and pulling resources, is this a better way forward for Nigeria? So those are things that we are also looking at. But I think just suffice to say that it's getting over the shock. It's looking at how we can mobilize more domestic resources in a more efficient manner, looking at more efficient service delivery platforms, and beginning to hopefully build back better our health system as we move forward.
When there's a crisis, one of the great things about this forum is there's a lot of wisdom in how you approach crisis. There are many here who've been veterans of crises of all types, you included, of course. And what I'm, gathering is that there's three ways when crises happen, three outcomes. You can get weaker. You can go back to the way things were, and you just said that's not likely. And I agree with you on that. I imagine many would here. Or you could get stronger through crisis. And I'm curious, you spoke about it from the perspective, of the most populous country in Nigeria. And I'm curious, Angela, when you think about moving from funding a health system to thinking about the people who deliver healthcare within that health system. You've been working with community health workers. You yourself are trained as a physician. And I'm curious how you see things. How has that workforce been impacted by the last 2.5 months? And what have you been doing to help stand with them to respond?
Thanks, and I love what Kelechi said, and I wanted to build on that in terms of zooming out. Resourcing resilience is resourcing systems that no matter how much can be taken, not everything can be taken away. It's about resourcing the system that actually delivers the healthcare. It's resourcing what might be harder to break down, but much faster and easier to build up. And so exactly what you're saying, at this time, what we're seeing is there has been a major impact. There's been a major impact in terms of the supplies, in terms of the human resources for health specifically in countries. Many primary healthcare facilities and also secondary healthcare facilities had a lot of co-funded or fully funded staff by our bilateral partners. And when those have been pulled away, there's a change in where people are seeking healthcare and how people are seeking healthcare. The hospitals are not in a position right now to fully be able to deal with the volumes of patients who are coming for certain particular services. And we're really glad that over the years and in the last decade, we have seen that governments across Africa have been reorienting their systems to be responsive to the burden of disease on the continent, which is largely preventable. And what that actually means is that you build a strong platform of delivery in the community where you have community health workers who are well supported, trained, and paid to deliver services at the household level to prevent illness, to prevent these diseases that then would potentially be complicated and go to the curative services that are more expensive. So we've seen that investing in policies, investing in systems, investing in community health workers have been a way to prepare us even for this crisis. We have seen that that platform of delivery, that first line of defense has been helpful. In Ebola, during your experience in Liberia, with COVID, we have seen that this system and the first line of defense constantly is activated in times of crisis to be able to be bridging that gap, but they're necessary every single day in delivering preventive services. And I'm glad to see that they are again stepping up in this period to be able to reduce the volumes of people going to primary healthcare facilities where they may not be able to find the services that they had been finding before because of what's going on in the countries. And funding and investing in this resilience is around making sure we have the right policy environment, we have the right funding environment for not just the human resources for health, but making sure that they're well supplied. And so there are multiple initiatives that have been in place to do this. As the team at Financing Alliance for Health, we have seen increased resources that the governments are putting on their actual budget to fund these human resources for health. And we know that domestic resources is a good play for more long-term political and financial sustainability for human resources for health. We have the Africa Frontline First initiative that is resourcing in-country partners that work alongside government to be able to co-deliver with government and support governments in reaching multiple people through the community health systems. And so the Africa Frontline First ensures that the ecosystem works well, that the policies are in place, that the funding is in place for them to complement and be able to reach a larger group of people. And when I think about the community health workers at the front line and delivering those services, I think about how do we make sure the resources that were there to give them the supplies that they needed will be there, and thinking around exactly what Kelechi was saying, what are the efficiency gains we can get with government and increase government effectiveness. In this time, governments need to be thinking about how do they do pooled procurement, how do they actually reduce the cost of supplies and make sure that those supplies not just get to the primary healthcare facility, but are able to get to the household. And there are people in the audience here like Michael who can help us think through what does that efficiency actually look like in making sure that the frontline health workers are supplied and are able to deliver the services. When I think about the initiatives that are also in place, I'm also very cognizant of the fact that in countries, we are able to see that there is an opportunity that exists. Because this big pot of funding has moved, to your point, when you enter a room, you can either look at the door that's closed or look at the doors that are around you that are open. We look at government budget and fiscal space, and in as much as there is highly indebted countries, there is opportunity to increase fiscal space with addressing the debt problem. Yes, this is a medium to long-term plan, but we cannot be playing in a field where governments are spending more in debt repayment than they're actually investing in key sectors in their country. So there are opportunities. There are opportunities to actually address that debt issue. There's debt conversion and debt swaps that are happening. There are guarantee products that exist. You can do debt buy down. I mean, there's a whole range of instruments available to us that we may not necessarily had the impetus to explore, but now that we are looking at the situation we find ourselves in, sustainability is something that is stewarded by in-country governments. To your point around the money that has moved out of the system, African health financing system, the reality is also based on the fact that we are staring at official development assistance, which was really significant and brought a different type of money, but we've been having remittances that have been coming into the continent that are multiples of what official development assistance have been coming.
How big are those remittances?
So in 2024, I believe, for example, the US government gave around $12 billion to Africa. In the same year, remittances were about 10 times what the US government was giving. And so people can say, but remittances go to families and they just use it at an individual level and just invest in, in a very disparate way. But we are seeing governments taking the leadership in developing investment vehicles where a portion of the remittances can actually contribute to the development of a country. So for example, the Agashiro Development Fund in Rwanda, the government has actually set up a fund that is able to harness diaspora funding that then invests in countrywide, national level investment. In country as well, we have massive pension funds that are already overexposed to government bonds, right? A huge pension fund in Nigeria, a massive pension fund in Ghana, in Kenya. And now is an opportunity to think through how do we actually tap into pension funds and be able to draw down on that money to advance development. And I see Amma is here, and she leads Gichaga fund, which is actually tapping into pension funds in Ghana and investing those pension funds in strengthening development across the West Africa region. So there were a lot of solutions that were at, maybe not at scale, and we didn't actually focus on them because we were, we had been put into this pigeonhole of money is coming in and we have to use it in a particular way. But to your point, in this crisis, in as much as the change was needed and the transition is painful and there are hard choices and trade-offs that will be made, we now have a bit more flexibility to think about how do we already use what we have in our hands, the domestic resources, addressing debt, tapping into remittances, being able to think about pension funds. There is somewhere to start from and be able to scale up.
Thank you for that. In moments of crisis, Bright, there's tension, and tension can be destructive, or as Dr. King would say back in the civil rights movement, you can also have creative tension that actually leads to something constructive. We've heard from Kelechi about a government perspective. We've heard from Angela about the role of various financing instruments, but also how the people on the front lines need to continue to be our priority. You've been working on product innovation in many different capacities and with the private sector. I'm curious how you're seeing things, Bright, and both from the various hats you wear, and also those product innovators you work with, and private sector companies, how are they dealing with this moment?
Thanks, Raj. So, in the immortal words of Bob Marley, so much things to say. But what I'm going to do is try and follow the lead of my two discussants and give us some kind of mini history of where we are. Sometime around 2000, we had the first Financing for Development conference in Monterrey. And then we went on, and I think this year sometime we'll go to Seville in Spain to cap it in a way of 25-year history. But right after that, I was beginning to become involved in local activism through affiliations with activist think tanks in Ghana, and also becoming a social entrepreneur who builds products on the ground. So my perspective is very bottom-up. And I think that is where the tension is strongest, between bottom-up innovators and actors and global systems and standards that sometimes don't marry well. And to my mind, the way that things went was that sometime around 2005, thereabouts, we started to talk about the Paris Aid Effectiveness Agenda of how do you make this whole global aid system much more responsive to domestic needs. We moved on and we went to Busan, then we came to Accra. And if you take the Monterrey Consensus all the way through to Accra, there was one resonating logic that ran through: the primacy of the domestic and the local. Throughout. The domestic is where innovation happens and it's where accountability happens, because the experimentation must be domestic. And you cannot do accountability beyond the domestic too much. There's a limit to how much you can do that. So for innovation accountability, it has to be domestic. And I think that is where we, in a way, have faltered at a global level. And I'll give you a few examples. All of us are mourning the death of USAID. It's tragic, and millions may well die, depending on how things go if some of these ideas don't get adopted. But the truth is that for many years, USAID had a 25% target for local actors. Just 25. Give 25% of the money through local actors to invest through various initiatives on the front line in the countries. They could never meet it. They could never give a quarter of the money to local actors. Yep. That's the truth. And then they managed to hit 10%. And then the last year before they were brutally assassinated, it was 9-point-something percent, 9.6% if I recall. That is the bitter truth. I remember that,
and that's in Ghana, or just?
No, globally. That was 10.2%, I think was the highest they went global. Now, as an innovator, I have spent years trying to solve the problem of visibility in the pharmaceutical supply chain, various health commodities as well. And in 2010, Nigeria became the very first country in the world where you could pick up an anti-malaria in a pharmacy and determine the source authentically. To date, you can't do that if you walk into a Boots on the high street in Oxford or you walk into a Walgreens in America. You can't do that. And yet still, not a day goes by that I don't hear about some global traceability initiatives with millions of dollars that is supposedly helping Africa. I'm like, where is this money going and who are they supposedly helping and who is supposedly doing this work? And maybe they are. But the truth is that for some people like us who have been in this journey for 20 years, not to know what's going on, not to be invited to these meetings in Geneva and the rest of it, tells you a lot about what's happening. Mm-hmm. And that is the truth. There was a huge gap, a huge gulf between domestic actors and global actors. We're talking about community health workers. We have last mile health here. We have CHIC that has just been awarded. People that are working in pensions like Amalati and the rest. And if you talk to all of them, they are on the domestic front line. This is where the battle is steepest. And every one of them will align on this view that they don't know where this global pot of money that is supposedly being distributed all over, how is that really financing the transformation on the front line that must happen? So this is a huge issue. On the accountability front, the Global Fund is a great organization. And the Global Fund structure requires them to have local fund agents because they don't have offices on the ground. Now, these local fund agents are primarily big four accounting companies, right? So PwC, KPMG, and the like. More or less, they represent the governance structure of the Global Fund in countries. So in my country, for instance, KPMG. You'll be surprised to learn that their reports are not public. So essentially, it's like saying that the local office of the Global Fund cannot communicate with local stakeholders because for some reason they think the reports will be misconstrued. So those reports go back to Geneva. Okay, fine. What about the country coordinating mechanism, which is the structure that is set up to ensure that there's domestic accountability, country ownership, the first principle of all of the global finance and for development strategies. I haven't read the CCM report in years. Because
CCM being the country coordinating mechanism.
Because they don't talk to us as domestic activists and innovators. And then recently, sometime in 2023, about over 400 containers of Global Fund goods arrived in Ghana. You'll be surprised to learn that it took a year before the last container was cleared because the government couldn't understand why, it should waive the fees of the custom fees or the taxes. Mobilizing through the Ministry of Finance was very difficult. But the most critical element of this was that the CCM did not have the political economic clout to drive through. That was the real reason. Because if people like us that are very loud, and I'm not going to make apologies for it, in the country were all involved from the outset, it would have taken 2 weeks. So these were massive amounts of resources brought into the country to try and transform the country. And from June 2023 to June 2024, we were still struggling to clear these goods because of lack of political economic commitment. The next point I'll make, which is related, is the fact that for the reason that this is so global north-centric and only a very small group of people are involved, has led to my mind, a massive limitation of the resource base that is possible. I'll give you an example. Nobody in this room will dispute that global economic power is shifting and that the so-called BRICS countries and the rest are making more and more of the money that is made in the world. Nobody will dispute that. Yet still, total contribution of the BRICS countries, Brazil, Russia, India, China, South Africa, to Gavi, which is the Global Vaccine Alliance, is less than 0.7% in the 5 years to the pandemic. Less than 0.7%. less than $55 million. Why would they devote so little to something that we all accept is global public goods? Because they are not that involved. A lot of the ideas that animate these initiatives, a lot of the principles that guide them are not still sufficiently global. And that is a problem. Let me tell you the money that is at stake. Total global health spending, the money that we categorize as global health, and that can be definitionally complicated. But let's just accept that these are conceptually valid. Total global health spending is less than half the money the rich world spends on chocolate a year.
Say that again.
Total global health spending is less than half the money that the rich world spends on chocolate in a year. The total amount of money that Gavi and Global Fund have raised since they were founded in the early 2000s to date is just a little bit above half of the money that we spent on Pokemon merchandise in the world. That's the blatant truth. We're talking about $100 million, $200 billion, less than $100 billion over a 20-year period for both Gavi and Global Fund. So these are, in the wider scheme of things, there's $4.5 trillion of financial movements in the US economy alone through FedWire every day. $4.5 trillion every day. So in the global scheme of things, these are actually very small amounts of money. The problem is that, as all of us acknowledge, there are segments of the global system, global development system, that we've totally delegated this pot of money. So when you talk about roads in Ghana, we don't really have a lot of global north interaction with roads, right? If you talk about housing in Ghana or housing in Nigeria, there is almost no global aid interaction at all with housing because there's not a lot of money that goes to housing. But when it comes to global health, for some reason, these are historical reasons, a lot of that money is tied to this specific pot of money. So the real thinking should be, how do we expand that pot of money? And we have some very good examples which we can start to build upon. The International Finance Facility as an example, and I'll try and end there. The International Finance Facility was this brilliant attempt to try and get vaccination money through the bond market. Very similar to how the World Bank raises its money, how the IMF and the rest raises its money. The truth is that through the IFF and through the private capital markets, the money that has been raised for vaccination is more than any single country has donated. Why is it not more? The $10 billion could be easily $100 billion. The reason is because of conceptual timidity. So rather than have the system in such a way, there are some countries that can pay for it. There were countries like India and the Philippines and the rest that were on these schemes for many, many years and could literally pay for it. We decided that we're only going to be donations from rich governments for the most part, and a little bit from private sector, and then the money was going to be given out in grants. That meant, therefore, that the way they designed the IFF in the markets was not really based on receivables, as the countries paying back. It was based on the idea that the donations going into the future will securitize the facility. The problem is that donations are always small. And if you really want a market financing mechanism, then enough countries that can pay back and take loans and things like that will have to have been built into it. So that conceptual timidity of not allowing that to be part of the parcel meant that IFF was always too small. Now, where we are in the world, we're going to have to expand and have situations where countries will have to make some payments. That's the literal truth. And then we use the rich country guarantees in the capital markets to borrow more money. But you can't do that unless you improve domestic accountability, because one of the problems with the IFFs was then to say that, okay, you know what? If a country has IMF arrears, then they can't be eligible for IFF money, which makes no sense because this was not loans. So why tie it to IMF arrears? The reason was they needed some kind of win-win mechanism. So my thinking around these matters is the global-local divergence and that tension even affects the design of global systems. I'll make my last point. If you think of the Global Fund and when it was being set up, and we're thinking, how do you manage the governance? How do you innovate the governance? One of the interesting ideas was that on the board, there should be somebody who is either HIV positive or lives in a community that is affected by malaria or TB. That sounds reasonable, except that in practice, this meant that the person who occupied this role has always been from the Global North. I think the current one is from the US, right? And it's only Global North patient communities that have always occupied this seat on the board. So it's not enough to just checklist, to do the design. You have to also activate it, which means the governance mechanism has to be live. And I think that is where the domestic piece is not strong. I think, for instance, that the strength of the voice of domestic actors in the design of global initiatives is way too small today, which leads to problems around levels of commitment and buy-in. if there isn't enough ownership from us. I think that
I mean, all three of you have taken the first part of this discussion and helped us both see the macro picture across countries, the role of public sector, private sector, social sector. We've talked a lot about where we are now and how we're dealing with the current crisis. Bright started to articulate, and I'd like to go there now, what is the new system we want to build? We do have this window of the next 6 to 12 months is going to remake the next, let's say the next, 2 to 4 months, might remake the next not just 2 to 4 years, but possibly the next 2 to 4 decades in global health. And so there's an incredible opportunity for all of us who are, in this space to do something now, to engage. But we have to be clear about what we envision a better system to look like. And again, Bright started talking a bit about some of the picture and how that might look, but I'm curious, maybe starting with Kelechi, and then we'll come to Angela, and then back to you, Bright. Tell us what that new system would look like. And then how do we get there? And then after that, we'll open up for some questions and come back to you for.
Thank you, and always very exciting, Bright. I think just 2 quick reflections, and then I'll answer a question. On the diaspora bit, I think there's a real opportunity. Yep. I think remittances to Nigeria last year, I think, was about $35 billion. And on Tuesday next week, there's a diaspora health insurance program that we're launching. And on Thursday, I'll be speaking at the Association of Nigerian Physicians in the Americas, who are having their first conference in Nigeria. So it's not just money, but also expertise, because we're seeing a lot of Nigerian physicians in the US, et cetera, coming back and setting up and bringing not just resources, but also their expertise and talent. So it's something we should definitely tap into, and there'll be more on that. And then, in terms of
how does it look? The future, if you could have a open canvas to design the future you want. What does it look like? How do we get there?
Yeah, I'll get there. And Bright, I think there's that agency problem in global health, right? These constructs of what we consider to be global, who are the principals and who are the agents? Who are they really acting for? When you have a system that is predicated on enlightened self-interest, it's hard to sell to the constituents of the countries that disproportionately contribute. And during COVID, we saw what happened with India with the export ban. So it's not necessarily peculiar to the northern countries, but I think it's this concept of solidarity that is fast eroding, and the fact that we're all reverting to very nationalistic tendencies that we need to address. And the structures that we've had have always had that problem where who are these entities really solving for? Are you solving for the AIDS patients in the country, or are you solving for those who are financing you, right? So that's a question that will always continue to deal with and to have, and that's why accountability is towards the funder, not to the people you're trying to help. And as long as that remains the dynamic at play, we'll keep having these questions and these problems. And again, from a country perspective, it's not a responsibility you can abdicate. You have to own your problems and you have to own your solutions. So if we were to live in a world where we were to democratize and bring this back, and you find out that many health systems, what we know as global now, evolved from colonial health systems, and there's a whole history and trajectory to where we got to where we did. And if you believe, let's use the analogy of democracy being, government of the people, by the people, and for the people. Then what does it mean to have a health system that is of us, by us, for us? For it to be of us, it means that it has to be one where we set the priorities. We're the ones that make the decisions on what to focus on. We're the ones that have the seat at the table. And the notion of global priorities that we have to tap into, we dissipate that. We forget that and look at what happens in countries. Why isn't sickle cell disease a global priority? So it has to be of us. It has to be by us, which means that the resources, the health workers, the platforms for delivery have to be there. We have to have more control of this. We can't have a country with 23,000 workers who are accountable to USAID, and when USAID leaves, what happens? So we're integrating them now, but we have to do better to build a system where supply chain systems, drugs being manufactured on the continent, etc. It's a system by us. And then when we say for us, do we want a system that trickles down? What's the role of equity in that? Who do we care about? In Nigeria, we've had a very elaborate and explicit equity mandate in what we do. So if I were to think of and imagine how we rebuild, we need to rebuild with a construct that solves for us. We need to have a system that is of us, where we set priorities, where we think through creatively how to finance those systems, where we think through all the factors for service delivery in country in a sustainable way to build that resilience so that it's not subject to the whims of any external party who may or may not decide to convince, whoever the principles really are. True agency is one that is really important. And of course, it has to be for us. The diseases, the research have to be targeted towards diseases that affect us. It has to have a strong equity mandate where we cater to those who are most vulnerable. That is the kind of system we need to rebuild.
Of us, by us, for us.
For us, totally.
It's very compelling. It's very compelling. I think that Angela, I'd be curious to hear your vision of that. Does that resonate with you? Where would you?
Absolutely. And actually, I believe that, especially what we were talking about earlier, Raj, community health systems are a great way of increasing agency, are a great way of actually advancing this for us, by us. Why is that the case? We are actually going to the communities and asking them, what services do you need? We are looking at the data. We are seeing that the data is showing that preventable health disease is the burden of disease. How do we actually equip community health workers at the front line, people who are trusted by their neighbors, by their communities to deliver the services? How do we bring community health workers? And we are actually doing this, Raj. We're bringing community health workers to the policy tables in countries. Financing Alliance for Health brings community health workers to co-develop not just the strategy and the policy, but say these are the services that we can deliver. This is what you need to consider in the delivery of these services. This is the support that we require to be able to serve our neighbors, bringing that community voice to the policy table, but then also increasing the transparency. So once the budget line is secured, how do we actually give budget transparency, the public finance management that is required in country to tell the communities, this is what has been allocated, this is what is being paid for, is it actually meeting your needs? It's bringing that agency even to the established ways that money is flowing right? So for example, when you think about what we are doing with Africa Frontline First and what we even plan to do in the next phase, Africa Frontline First is recognizing that there is different types of money with different comparative advantages for funding global health. It's going to the global health architecture, to the global fund and saying, you have had this mandate in the past around the 3 diseases. How do we help you fund better in terms of a more integrated way, aligned to government priorities? It's being able to look at the different types of money, crowding in the philanthropic money. For example, we got some money from Skoll Foundation and J&J Foundation, which unlocked additional money within Global Fund and was able to, increase, the fund of money about $100 million to not just fund in countries, but to fund government priorities. So we have these local actors and the government setting their priorities through the policy and making sure that this global funding that's going into country is aligned to that priority. And we are seeing this working because as you think about how do we need to re-engineer this health system on the continent, it's you are creating a new, but you're also changing what exists. And as you change what is existing, it's how do you actually inject the principles of what the change requires on how the global funds flow, and then how do you actually create new systems in country to match that. So the Africa Frontline Fast so far has been able to unlock an additional $119 million from domestic resources. So you changed the money, how it was flowing globally, and that flow increased and was able to activate additional resources in the countries. And we're seeing that now this money, as you're saying, Kelechi and Bright, then becomes the resources that are more flexible to fund alongside government priorities. It's about the political engagement. And I like what, Bright, you are alluding to. For a long time as health players, we have distanced ourselves from the political game, right? And the truth is, resource allocation is not just a technical, it's a political engagement, right? And so if we continue just saying, oh, this is the investment case and it's right to invest and these are the numbers, you won't win the game fully. You need to get involved in the political process. And it's not just a policy process. It's not just getting the strategies in place. It's making sure that people who are making decisions on how funds flow, who are not necessarily health technical people, are able to understand the priorities and be able to put their money towards those priorities. I honestly believe that the path forward is integrated service delivery. I honestly believe that the path forward for us is making sure that everyone is involved in re-engineering these health systems, and there will be primary healthcare systems. And that's why, as Kelechi was saying, when we have the patients telling us what they need, not us having the arrogance of telling them what we believe they need, but them telling us, this is the services we need, this is where we want to receive those services, this is how we want to receive those services, and making sure that that voice and agency is captured in-country policy and strategy, and that the government itself, as you said, who has the duty of care to actually commit its resources, does that, and then other resources is aligned to government priorities. That's how we're going to change the system. It comes from the community. It's the community to tell us what they need and how they need us to show up. It's us to show up for the community because it's our duty as people in that country, as government, to show up for our communities. And it is our duty as people in that country and government to tell others how they need to show up for our communities as well. So it's recentering the power to where it needs to be and who is the steward of the conversation. But it's making sure that we are also making the best use of what already exists and reshaping that even as we are creating a new reality for ourselves.
And last night we actually saw a manifestation of that. For those who attended the award ceremony, and Trevor was great, and Shaka Khan was good too.
She was fantastic.
Awardees were also the stars of the night, and one of those awardees, alongside Madeline Ballard from the Community Health Impact Coalition, who I know you collaborate with closely, was Margaret Odera.
Yep.
And Margaret, of course, is one of those community members who has, was expressing her agency on stage as a community health worker serving her own people, and said nothing without us, nothing about us without us.
Without us.
And I hear you making the point that as Margaret has done, thousands and tens of thousands of community health workers in Kenya have organized and have been demanded that their people get health care, Margaret being at the spear tip of that. And I hear you saying that should be also part of that vision of the future and a part of how we get there.
Exactly.
So,
Raj, sorry, before we move to Bright,
Yeah.
I'm also wanting to make sure we don't get the private sector off the hook, right?
Yeah.
Because when we talk about domestic resources, it's not just domestic on-budget resources, right? There's private sector in the room that I perceive has suboptimally engaged with the primary healthcare systems and overall health systems. It's not just about building hospitals and delivering services. Private sector has such a huge role to play, and this partnership and collaboration. And PPPs go beyond infrastructure. There's so much. There's a plethora options that can be
You
explored.
mean private-public partnerships?
Yeah, sorry, public-private partnerships go beyond just infrastructure projects, and there's so much opportunity to blended financing. So again, the private sector is at the table. It needs to speak louder. It needs to lean in more. I believe as we tap into these different sources that have been disparate because we were emboldened by existing resources at the time, we will be able to get, we may have less than we need, but we have way more than we think in our countries, and we are really not utilizing those resources because, again, to your point, you enter a room and sometimes you spend too much time, you can look at this locked door, but we're spending maybe too much time looking at the closed door and not really seeing what we already have in our hands. I did not mean to interrupt you, Raj.
Oh, it's a brilliant point. To move from crisis mindset to opportunity mindset, the private sector leadership needs to be there. Bright, you again have spent a lot of time as an innovator, as an entrepreneur, and you build on that for us. What is your part of the canvas? If you're painting that side of the canvas, what does it look like? The vision for the future, and how do we get there?
Thank you, Raj. So, in addition to obviously being a grassroots innovator, I'm also deeply involved in the policy conversation. And therefore, I kind of see my thinking increasingly shaped by the political economy of these issues. And especially in Africa, I think the political economy is critical. So to touch on some of the things that have been said already, my view is we have to pay additional attention to the Alma Ata Declaration around going beyond technical interventions in health and thinking holistically. If you think about private sector interventions, I always tell people, think about some of the successes that we chalk and we tout the most when we think about global public health in the last 3 decades. Maternal mortality, infant mortality. How much of those gains should be attributed to nutrition, for instance, as opposed to technical interventions in classical healthcare? Nutrition is massive. I've seen studies that suggest maybe 55% of gains in some of these areas are actually nutrition related, other than medicine or something like that related. Now, if you bring the private sector on board, but you think, okay, we've defined health in such a narrow fashion, then you're going to have pharmaceutical companies, and they're going to be the only people around the table. And of course, then you're going to have activists all around the world up in arms. I was looking at the recent board composition of the Global Fund, from a political economic point of view, and I was realizing that the private sector representatives actually from an NGO. And I know why that is, because if they put somebody from Unilever on there, think about what the NGOs are going to say. So my view of the matter is that without a holistic reframing of some of these issues on social determinants of health, Amata and the rest of it, it gets very difficult to be expansive, in the way that we bring in the private sector. The second point, which I think is also relevant, is the fact that in Africa in particular, and here I'm still talking about the political economy dimension, the issue of collective action is a big challenge. So we constantly talk about, the Abuja Declaration and going back and making sure that we have an integrated continent that really leads forward. The challenge is, and I call this the paradox of fiscal essentialism, by which I mean there is often the case that things that are important appear to be a bit too fancy, and therefore we can't fund them because we don't have money. So the average African country deprioritizes paying their African Union dues. So this is the way the African Union financing situation works now. They need about $600 million a year. Of the $600 million that they need in a year, governments can provide $200 million, which is 33%. So-called international partners, which I think they are too shy to list them in full. So when you look at the chart, you see IPs. And IPs actually means rich countries in the global north. They are responsible for $370 million. So nearly 60% of funding the African Union has to come from overseas. One time I was checking the AFTA Secretariat, the Continental Free Trade Agreement Secretariat, and I think nearly 80% or so of programmatic funding, the funding that will actually lead to the creation of the single market, comes from overseas. So you have a situation where things that are important are in the soft development category, because you don't see them in roads and buildings, right? You see them in institutional renewal, you see them in innovation, you see them in equity. Those kinds of things, we say they are not essential. We don't say it upfront. But when you look at our actual spending pattern, we don't put money into it. And that's one of the biggest reasons why in other places, they got aid and they rapidly industrialized. Think of China getting $21 billion nominal from Japan over a 3-decade period, and then using that money to radically industrialize. In fact, the last amount of global aid transfer from Japan to China was in 2022. If you discount that amount of money, it's over $100 billion that Japan gave to China for China's industrialization. The difference between China borrowing like that and low-interest loans and using that to industrialize is that China was responsible for the soft development aspects of its own policymaking. Somehow, the African countries have underinvested in that soft development piece of the puzzle because we claim that these are not priorities. So you think of the Young African Leadership Initiative, and you bring African leaders all over the continent together to build bonds. This is going to be critical for the future of the continent. 99% of that funding came from USAID. Because if you try to get African governments to put in money, they're going to say it's not essential. Why will I pay money for global leaders from across Africa to come to Accra or whatever? It's not essential. So it's a paradox. And it's arguably defensible to argue that it's not essential. So you have a lot of very important things that you need to hardwire the hard development aspects, the roads, the ports, the hospitals, and the rest of it, to make them productive. If you don't fund that sort of development, what happens is the money that you use in buying the hard development becomes debt traps. And that's what we saw till the 80s when we had the London Club crisis and then the HIPIC. Because you build all these roads and the rest, but the productivity boost doesn't come. And the challenge we have to figure out in that regard, therefore, is how do we fund soft development? And my soft development at this stage is the African Continental Agenda. Agenda 2063, the AFTA, the single market. These are hugely important things. Why are they hugely important for global health? I'll give you a practical example. We've talked about it already on this panel. Pool procurement. We all know that pool procurement will solve so much because it will massively expand our bargaining power. If 55 African countries were all procuring together, pharmaceutical companies will stop bullying us. Everybody knows that. Try and get that working. Ask my sister, Fatoumata Ba, who tried to work with Strive and others to build the African medical procurement pool mechanism. And she will tell you it's really difficult. African governments will not fund initiatives like that. And it's not hard to understand because, we got to build roads, we got to build schools. Why would we want to fund something that looks fuzzy? So we got to figure that out as far as that particular issue is concerned. The third one, which I think will unlock a lot of money, is this fascinating point, which is that there is still, despite USAID and everything that you talk about, there's still so much more money that is stuck and can't be unlocked within the existing system that all of us say must be reformed. I'll use the most prominent, the MDBs, the multilateral development banks. In the World Bank system, I calculate that of the committed money, the money that you've already decided they're going to give out, only about 35% is released within reasonable time. Because you have two levels of problems. One is that the disbursement is based on countries meeting various requirements. So that's the gross disbursement. Once the countries have met those requirements and the money has been released, they have to spend according to very strict criteria. And if they don't, what then happens eventually is that some of that money doesn't get released. So ultimately, you will see a $100 billion commitment to this number of countries, only $35 billion is going through. That tells us that there's a lot of money still in the system that is stuck. How do you unstick it? The way you unstick it is improve domestic governance capacity, so the things that has to be done to unlock that money will be unlocked. To fund that, we can rely on foreign goodwill partners to do it. We have to figure out our own way to do it. Recently, I was looking at some of the World Bank's portfolio items in Ghana, and I discovered things that shocked me to my marrow. There are projects that are well described.
Not to the bone, but to the marrow.
The marrow. To the marrow.
A whole nother level.
There are projects well described in documents, well, examined, everything else, everything says beautiful. You go and you look, and the projects don't exist. No, they literally don't exist. Why is that a problem? It's a problem because then money that is available and available to spend somehow is not getting to the projects. So we have to unlock that money. And I think if we did that, we'll probably triple global health financing in Africa simply by unsticking stuck funds. And I think enough people don't pay attention to that problem.
The three of you have given us, you've added now the power of private capital and some examples of how that could be further deployed. And you made a very important point about the Africa Free Trade, Continental Free Trade Agreement will increasingly become the largest market on the planet with the largest...
By number of participating countries, it's already the largest.
Exactly. We'd like to turn it out to the audience for questions, and we probably have time for a round of, so we'll take maybe 2, and then if we have another chance for another round, we'll do a second 2 questions. Questions for our panelists. And we have some bright orange scarfed colleagues who will bring it out. So just raise your hand if you'd like to be called on, please. And say your name and just...
Good morning, everyone.
Good morning.
It's been a very insightful session, I must say. Thank you. My name is Ebukai Mebina. I'm from Impact Entrepreneur. My question is around, at the beginning of the session, we talked about the macroeconomic frameworks and the challenges that projects on African countries. So I'll give an example. A reasonable number of HIV vaccines or the treatment drugs are imported. So what that means is you have a foreign currency problem if you have to finance it with your local currency. So with a cutoff of international financing, for example, it means that from your local resources, you need a lot more to actually procure those drugs. And that amount that you need keeps increasing the more your currency deteriorates. So my question is, what's really the plan, for example, for production on the continent?
Yeah.
Some form of intellectual property transfer. We saw that with COVID. I don't know to what extent that actually progressed, but how can that be addressed? Thank you.
So production of medicines, vaccines, diagnostics, I would assume, medical supplies on the continent. And so we'll come to whoever would like to take that in a moment. Thank you for that. Is there another question? Please, yeah.
Hello, my name is Svetlana Chigozia, and I work for the Eco-Anxiety Africa project. And in our work, we're seeing that there's an increase in young Africans experiencing the mental health impact of climate change. And when we speak to elders, they're also experiencing it too. And if we know that climate events are only going to increase, then we know that this is going to get worse. So how can we include the fact that mental health exists, mental health issues exist when we talk about health in Africa? And how can we collaborate together to receive funding that deals with the issues that are seen, but also the issues that are invisible? Yeah.
So maybe we'll come, Kelechi, to you about the question of how do you build production on the continent, and then you could take the second question, Angela. Then I think there are 2 more hands on this side I saw that we could try to come to you. If you could each be brief in responding, then we could get to a second round of questions.
I think it's a very important question that you mentioned, and I think it was very glaring during the COVID pandemic. And many countries, first of all, when I used to work for Gavi, there was there's an initiative to actually promote local manufacturing on the continent. I know in Nigeria, the president set up this entity with the national coordinator called PVAC. It's really to unlock the healthcare value chain that looks at everything from manufacturing all the way to actually distribution and hospitals, etc. And this is with a view to, and it's not just an economic issue, that's the thing. It's also a human security and health security imperative. We don't want to be caught out the next pandemic to find out that we're waiting and praying for drugs to come, to come from somewhere. And so I think this is one, in Nigeria, definitely we're doing this. But we also have to look at the markets, right? Not every country can have manufacturing capacity and capability. So in the principle of, the Africa 2063 agenda, etc., we have to look at how we could also be more efficient. But local manufacturing is something that is critical, and it has come to stay. But it goes also beyond manufacturing drugs. It's also looking at shaping the local markets. How will it be paid for? Service delivery points. Even in Nigeria, we're also looking at services, reducing outbound medical tourism that costs about $2 billion a year, right? So what are we doing to keep those resources in country, but also secure the health and well-being of our citizens? And I think this is the overarching premise for it.
Yeah, Bright, you wanted to come in on this?
Yes, I just wanted to let the person who asked the question, I didn't get your name, unfortunately, sorry, know that there is now very good case studies around the effort to produce COVID vaccines and other vaccines on the continent from BioNTech and others, the modular strategy.
Yeah.
And the latest resource is that, like Kelechi said, is really volume driven. So unless you can aggregate some markets together, it gets really, really challenging. And that is where the issue around how does Africa work together becomes so critical. So far, only the Rwandan one has been able to go across the line. And even that, with the 2024 assessment, the case study shows that, like everybody now knows, manufacturing is only 50% manufacturing. 50% is also logistics, services, design, marketing, etc. So you need to have all that together in order to build effective production on the continent. So you should check out that case study and others of that ilk if you're really interested.
I love what both of you said, and just moderator privileged because I've been spending more time over the past year in biotech investment, venture creation. I just want to add to it to be a little provocative. You can always tell where in as you mentioned, paradoxes or contrast, where some of the gaps need to be closed in terms of how we approach problems. And the gap I'm speaking about here is, we spent all this time talking about manufacturing, say, vaccine. But we haven't talked about investing in scientists in Africa to innovate and create the vaccine, and then having them file intellectual property so they can create their own companies and they can create their own wealth. And the venture world and the private equity world can come and actually fund them. That world is much more possible and also would feed in to the kinds of manufacturing goals you're talking about, especially because the free trade agreement is on the agenda. And with that is the Africa Medicines Agency, which would allow the regulatory capacities of
harmonized
to prove medicines, to prove vaccines and treatments. So that too, I think, needs to be on the continent. I can't think of a single scientist I know on the continent who doesn't want to be able to take their innovation, create a company if they want to.
And Raj, you're absolutely right
invested.
that if you want to license a molecule in the African market with 10 million buyers, if you're extremely lucky, you have to go from market to market, going through the same process over and over again. It makes no sense.
That's not, and in Cambridge, Massachusetts, the way we've built biotech innovation ecosystems is because those pieces have come together, the science, the entrepreneurship, and the capital. But it's something that I think should be part of this conversation. The question about mental health, and we'll come back for one more round before we close out.
Yeah, and just to close out that, I agree with you, and I also say sometimes we also just have to have look at our risk appetite and redefine what we're saying is risk. And there are always existent scientists, and I like what you suggested. Someone like Yao Bediako, who runs Yemachi, again, started his own biotech company and raising money and doing amazing work. But again, getting the dollars to support is one thing. But to your question, I do think that, again, when we talk about integrated services, it's not just integrating the health services, but defining health much broadly and the social determinants. And so it will require a multisectoral approach to the question that was asked. And how do we define that multisectoral approach? How do we talk about well-being as opposed to health? So it's not just about curing you when you're ill, but actually trying to prevent you from becoming ill. And it's a whole other multisectoral approach to it. And I agree with what you're saying is as we continue to have the opportunity to redesign, re-engineer our health systems, when we are bringing in services to national health insurance in terms of the essential packages, how do these areas of health that have historically been ignored become part of the reimbursements for the national health insurance more broadly? But I agree with you and want to even build on that a little bit more. The way we have defined certain health interventions is what is actually, not helping us invest as much as we want. So if nutrition wasn't the responsibility of the Ministry of Health, but was a shared responsibility between Ministry of Health, Agriculture, and Education, we would see more robust and comprehensive initiatives coming to address the nutritional problem. But now you put it in one ministry and responsibility in one ministry, and that limits not just the resources in terms of people and time, but also the money resources that can be put behind it. So again, for this mental health and climate and youth, this again should be a multi-sectoral approach.
Thank you. We have two questions here, and I think we'll end with those.
Hi, Dan Palazuelos from Partners in Health and Harvard Medical School. I've really appreciated the insights you have given us about a lot of these bold financing and funding mechanisms. And Angela, I really appreciated your comment about how it's not just about policy making, there's also a tough politics, which brings me to the question of, there are more than the low-hanging fruit ways to move into markets that are there. There's also deeply entrenched problematic funding mechanisms. A lot of sub-Saharan Africa continues to suffer from extractive industries that are really remnants of colonialism and colonial power. There's very large offshore accounts that are serve as tax havens. This crisis sometimes starts to break down world orders. And I wanted to just get your reflections on really what might happen when looking at these deeper, more entrenched processes and pockets of money.
And Dan, you mean what might happen, just maybe add on that?
What do you think might be a mechanism in which these might be observed as potential areas for reform or maybe even for financing? And then what even might be the role of people such as those in this room or listening in terms of putting shining a spotlight on that reality?
Very helpful, thank you.
Thanks.
And your question, please.
Thank you. I'm Matthew Hanning from CBM Global Disability Inclusion. We've been hearing about the cuts, and we know how these cuts and the impact affects us all, but we know that it doesn't affect everyone equally, and the most marginalised are often the most impacted. For example, even in the UK government 2021, ODA cuts cut by about a third, but impacted gender and disability and other programming for the most marginalised by over half. So I guess the question is, how can we, when we're reimagining resourcing resilience into this new future, how can we mitigate these risks that the most marginalised, the most left behind, are actually included and not more impacted than others? Thanks.
Great. Anyone want to chime in on either one of those? We probably have a chance for one respondent for each question, then I do want to hear you give us a call to action after that, so I'll come back to you once you've responded. Anybody want to respond to the first question Dan asked about the role of examining extractive industries and how that might play into the reform, and then the question about marginalized communities being excluded, how do we not leave them behind?
So on the second one, I mean, I can speak to that. So because in Nigeria, what we did was created a vulnerable group fund where we identified, different pockets of vulnerability. We have one of the largest numbers of internally displaced persons, so we identified that category. We also included people living with disabilities. We also looked at the elderly because elderly poverty is a big issue in many instances. And then we also looked at acute vulnerability, so women who are at risk of dying in childbirth because we had some of the highest maternal mortality rates. And so we had like a free emergency obstetric care program that the NHIA pays for, amongst others. So I think it's about being intentional. And when I talked about building a system that is for us, it's being very inclusive and ensuring that when we're trying to achieve access or universality in access to healthcare, we are intentional about including vulnerable groups and vulnerable populations, and not just let it trickle down from first those that have to them. So I think that's a very important element. Secondly, in terms of the benefit package, so I work in insurance, so I think in terms of that, I had a meeting recently with physical therapists, physiotherapists, and those in rehabilitation. Again, these are not things that are, because we have mostly medicalized systems and that are not fit for purpose when it comes to looking at people living with disabilities. And so how do we have an expanded view and perspective of what care should be, including rehabilitation, but also thinking much more broadly on the prevention element and all that. So there are many ways to tackle it. And from our lens, from insurance, that's one of the ways we're looking at that level, that degree of vulnerability, and how are we intentional about addressing that.
Thank you. And Angela, maybe you want to take Dan's question or Bright about extractive industries. Either one of you want to jump in on that?
I think I lost it a little bit in terms of the connection between extractive industry specifically.
Yeah, I think Dan was saying that, or Angela, do you want to jump in?
Yeah, I can reframe the question and then you can answer.
Oh, okay.
Well done.
I know. I tap you in. So basically what Dan was saying is that we have an extractive industry across the continent that is not beneficial for the continent, and there are opportunities to actually secure resources that can be used for development. There's also, creative accounting that happens on the continent where people are able to gather resources that don't accrue to them normally, and then they hide them in other geographies, and what mechanisms can be done to increase not just the visibility of those resources, but also the backflow to the continent to advance development. So, Dan, did I do a good job? Fantastic. Over to you.
Absolutely. No, I think that we've had a legacy extractive industry sector in the continent that all of us agree have not served us very well, in oil and gas, in gold and precious minerals and the rest. But we have a new opportunity with green minerals. Some call them critical minerals, where we have to think very differently. I'll give a very practical example. In batteries technologies, for instance, we know that there is a direct connection between batteries technology and air pollution. Because if you can shift as much of the fleet in Africa to electric, you solve a huge problem with air pollution, at least smoke, right? And we can do the same also with actual industry by moving it to electric. Most of those minerals are in the continent, but they're distributed. So Ghana, for instance, has lithium, but the phosphate to do LFP is in Togo, right? And so if you want to do battery technologies, you have to have these integrated supply chains that bring one green mineral from one country and another green mineral from another country, and then have hubs where electricity is cheap, hydroelectric power in Congo. So without that kind of framework of thinking about how we make the green minerals more value adding to our continent, and use all the learning that we've done with legacy industries to enhance that, and then connect that to the benefits in healthcare, I don't think we're doing the math right. And if we don't do the math right, the money doesn't flow in. And if the money doesn't flow into those sectors, transformation is very hard. So I think it calls for a very broad, multidisciplinary way of thinking, as well as the ability to work together as a continent, which I think is the heart of all of this. If we don't work together as a continent, I'll give a very large example. The European Parliament, was something that more or less was conceived as a Strasbourg entity after the African Parliament was conceived. Today, Europeans can directly elect an MEP. I can't elect a member of parliament for the African Union Parliament. Why are we so slow? We need to figure out how we build our institutions as a continent at a much more rapid pace. And solving some of the problems that you talk about without thinking about the regional value chains approach is just not going to work.
It's a very good point to take us to our last question. We just have 5 minutes left for the top of the hour. While we're going to close out with this, my father, while I was growing up in Liberia, had lost his job, and he, we have these famous bumper stickers on our trucks in Liberia that have very profound meanings. And he was stuck in traffic on the way home after losing his job, and he looked up and he was depressed, and he saw this phrase, "No condition is permanent." And for the longest time, just to make up for my Liberian Jollof bravado earlier, I thought it was from Liberia. In fact, it turns out it's from a Nigerian novel. And the basic concept has come to mean, at least in my family, that sometimes we can't choose the conditions we face, but we can choose how we respond to them. All three of you inspired us with how you are responding. I'd like you to provoke and challenge the audience. If you were to sum up a call to action of how you'd like to see this community respond in this moment, what would it be in 2 words or less? I'm kidding. You can do a line or two, just given the time we have, and I'll let you start, whoever would like to. We would love to hear from all three of you.
Okay, sure. So just wonder how many social entrepreneurs are here? Okay, thanks. How many government officials are here? how many policymakers are here? Let's expand it a bit. So I think Angela mentioned something, which is the importance of, healthcare is very political. And we've seen how, whether it's in times of crisis like pandemics or now with the disruptions we're seeing, politics plays a very important role. And I think politics is too important to leave in the hands of professional politicians.
True.
And so my call to action would be, as fantastic and amazing as it is that we do what we do as social activists and actors, it'll be to get involved, lean in, be part of the policy process, and be part of the politics. Julio Franco's always said there's a difference between politics and politicking. Politics is inevitable. Healthcare is extremely political. It's dirty. It's not, you can't tell a clean linear story. So my call to action will be to engage in the political process and to engage in politics.
Thank you.
I was reflecting on a quote, and I'm very infamous or notorious because of my quotes. And this quote by Martin Luther King that says, we can accept finite disappointment as long as we don't lose infinite hope. And it's not unrealistic and unbridled hope, it's realistic hope. And I felt a lot of hope during this week, which I really welcomed. And the reason I say that is we are all impacted with what's going on in the world, each and every one of us. This is not an opportunity to other someone else. It involves all of us, and we are all impacted. And that means that we all have something we can bring to the table, individually and collectively. If it's at an individual level, maybe you can be a sounding board for an enterprise that is going through a rough period of time. Maybe you can be coming together as a collective to come and advocate in country with your governments for certain policy changes and shaping that. Maybe you have resources that are unrestricted that can be able to be invested in so many initiatives that are existing at a sub-scale level that can be taken to scale. My call to action is that this is not an opportunity or a time to other this issue to other people. It's a reality check for us to recognize that we are all impacted in one way or another, and we all have resources in terms of our talent, in terms of our time, in terms of our treasure to actually be part of the change of re-engineering the healthcare system that we want. So that's my call to action. What can I do? What am I able to do? And what can you do? And what is it that you can do at an individual level and also as a collective?
Right, get the last word.
Yeah, a modern wise man recently said at an event I attended that if all of us had a chance and a choice in redesigning the global health system, none of us will create what exists now. None of us would. So that tells us there's a huge opportunity for transformation. Two quick calls to action. One is stop treating Africa as a place where you dump your pity, right? Africa is going to be the most important player in at least one respect. The demographic capability that we have to generate talent is unbelievable. In a few years, the average age of a midwife in Portugal will be 65. You're going to need talent from Africa. It costs $425,000 to train a doctor in the UK. It costs $20,000 in Ghana. And we have a lot of these doctors going to be trained. It costs about $90,000 to train a nurse in the UK. It costs less than $9,000 to train a nurse in Ghana. So African talent is going to be extremely important in the global health system. So that's number one. So pay attention to that. Number two is the fact that you can't do global devolution the way that we've done it, where we've thought that all we have to devolve is resources. What we have to devolve is power. And until we devolve power, devolving resources won't happen, and it's meaningless. I think Africa has to have an agency about that. We can't wait for the other people to devolve power to us. And one of the things we're going to have to do is to fix our internal cohesion. There is a call for airline taxes to be used to fund the African Union. Every time that comes up, the airline lobby in Africa defeats it. And yet still, with a 2% tax on tickets, we'll be able to fund the African Union and not have to rely on external assistance. this is a very practical call. Can we start to pay attention to these kinds of details so that when we are mobilizing, we mobilize towards power?
Power's never given, it has to be demanded. So thank you for that. Yeah, thank you, everybody.